think you guys are being tested. I have both Dr. Highlands here watching me as I'm gonna be my quote-unquote assistants. Anyway, so for the hip, we'll start with distraction. So the few ways you can do this, like Dr. Highland mentioned, Matt Highland mentioned, is that it's easy for a lot of people. I'm going to show it the other way. Is I know you're getting distraction at the ankle, the knee, and the hip. Sometimes it's very tough for someone who's say dealing with a leg that's a person has very obese, fairly large, maybe like 6'7", and you have someone who's like on the shorter end doing the treatment on someone. So bend the knee. So I always want to know that the other leg is or the back is being supported. So I'll tell the patient to bend the opposite leg while I'm going to be doing the distraction or mobilization to the hip. So here what I would do is I would come out. Now open back position, the hip is what? Someone tell me.
Oh, Jesus. Slight
Fade.
internal
Fadir,
flexion.
adduction,
Slight
internal
abduction.
rotation.
So you have 30, 30,
Fadir.
like 10 degrees.
Right?
Whatever it is. 30 degrees of hip flexion, 30 degrees of abduction, and
favorite.
about 5 to 10 degrees of external rotation. Slight Captain Morgan stance. And what you do is Captain Morgan, and you just gently pull, and again, it's not the ideal way. I'm going to show you the other way. And then you oscillate. It's just easier sometimes for the physical therapist to do this if they're handling someone that's much taller than them, heavier than them. All right, you want to do this for assessment. Like Dr. Highland said, 10 seconds. Do this up to like 30 seconds or a little more. Again, you're doing this for patient comfort, making sure that they get less apprehensive. And multi-axial distraction helps with all movements. All right, and you gently release. Remember, don't just jam it back. And reassess the passive range of motion. You're always doing that first, right? Passively, ranging them, and you're checking the uninvolved side first. So the other way to do it, and I can show the way with the belt or without, is to you go underneath. Again, I can lower this for myself if there is. No, that's fine. Come towards me a little bit so I'm not leaning like what Dr. Highland said. You also have to watch out for your back and your mechanics, right? Make sure the patient's comfortable too. You okay?
Mm-hmm.
So again, I take them down here, 30, 30, a little bit of lateral rotation. I'll put in a headlock position, and I can just pull. So now I'm getting more of the hip. I'm getting some of the knee, but the hip is tough to handle. Is there another way you would do it too?
What is this for?
For the hip? You're
Distraction.
trying to keep it as
No.
the assessment.
Straight, yeah. Open back.
So this is all the biomechanical, this is where it gets a little complicated, right? So the osteokinematics at the hip, flexion, extension, adduction, internal, external rotation, right? It's a ball and socket joint, but much more stable than the shoulder because of the deeper labrum, and a deeper socket, but also because of the labrum as well. So when the hip comes up, basically at the crease, right, it turns in quite sharply and articulates. So if it's here, right, what directions can we mobilize the hip? Anterior, right, posterior, inferior.
Laterally.
So lateral and distraction, depending on what you're reading, slightly differentiated, but mechanically almost is the same thing because, right, if it's coming up, it's articulating, lateral is this way, right, straight this way, but since it's not a 90-degree turn, right, at the femoral neck, so lateral would be that, distraction is going to be that. So they're slightly different. They're slightly different on a test piece of paper. In a clinic, it's very, very different. It's very difficult to make those separate. But in theory, to get true distraction, right? So you're letting your shoulder handle the flexion, the abduction. You got to get on the medial thigh, and the force has got to come this way. So you got to kind of pinch in, you got to lean down a little bit, right? Because you need to come this way and then that way. Does that make sense? Okay, so a little bit of, so what Dr. D was showing you, kind of getting the, so there's the out and the distraction. So I'm almost putting a little force of my shoulder to stabilize here while I'm pulling here, then here. A lateral glide would be purely this way, which is really hard to do, you know, without getting really high up into the groin area. That's where we're going to show you the belt, because that is a great way to get in there, because it's legs are heavy, you know. But I agree with Dr. D. That's what I do a lot of times. I'll come right in here, exactly what he showed. It really is more of a kind of inferior, you know, but if you come out and do a little bit more abduction, you're getting a little bit of distraction on there as well as your inferior motor. So, you know, it's a tough one. The belt is the answer, is how I would typically do it. But you can't feel as well, right? So we're using a mechanical advantage, but now you don't have your hands on there. You know, if somebody's small enough, I'll get in there and do that, but legs are heavy, you know.
Yes, they are. So going to the lateral glide, so I'll show you with and without the belt. So without the belt, what I do is I'll crouch. I'll make sure if they're okay with this. I always check in with the patient if I can do this. So my chest, or if a female's doing this, you can put a pillow as like a barrier over here, right? But what I could do is from here, just distract and find the grading I want. But this is pretty much what a lateral glide would be.
What are you pushing in with your chest?
Chest is like just it's a barrier, and I'm just doing the movements and the mobilization with the hands that are overlapping each other. Okay, and again, what I'm doing is I could do straight. I could do a little, like a J swoop they call, like just go this way a little bit. So I'm taking it out from the labrum, so it's not hitting. But just find your and then do the appropriate grading. Okay.
So are you using your arms to pull my leg, or are you leaning back?
I'm leaning back a little. I'm using my chest too.
Yeah, perfect. The answer to your question is no, but it's sort of yes, right?
Yeah, it looks like it.
He's stabilizing here, but the mechanical advantage you get, remember, right? So here's the femur. If you push here, right, think of what has to happen. So he's getting automatically, the therapist is automatically getting a little bit just with that little move there. Now, you're not going to worry about trying to create this, but you'll gain the mechanical advantage with a little pressure here, and now you're going to do the motion up here. So this becomes a stabilizing force, but you've already taken some slack out by making that little motion with the stabilization of your body, right? Because it's just a pure lever arm. So if he puts that pressure in, you're going to naturally get that coming out, right? You always got to think anatomically, like what's happening, right? If I push here, what's happening? You know, and that's where these all really work well.
Any other questions?
I have a question. So you're not worried about the contralateral hip, whether it raises or kind of like moves with you or not?
Well, you want to always be aware that, you know, you don't want to do too much of this movement going on other parts. So I am aware. I'm just trying to stabilize the best I can and just get the pure movement coming from where I want to have happen.
One thing he said earlier that's spot on is, you know, when the knees are bent, it takes the pressure off of the back. In the clinic, which we don't have, we will have, we just don't have them, we don't know where they are, is a bolster, right? So this is a moving part. If she's trying to, the patient's trying to hold it there, but if you had a bolster here, that would just be resting right there, right? You'd just have it from here over. Now this is just quiet. There's nothing happening there, and it's purely relaxed, and you don't have to worry about doing anything. We just don't have the bolsters in here right now.
Got to work with what you have. That's
Right.
another thing too. I'll tell you a story for this. What happened the other day. Okay, so easier way is you always want to put it around the gluteal fold, a little just above the belt. From here, all you want to do, and I have a towel here because the pressure, I'll let them know, like, you know, the pressure that you're going to feel. Let me know if it's uncomfortable, but the pressure that I'm going to pull might create a lot of, on the inside of your hip and your knee. So then I'm just going to, everything's, bend your knees too, right for your back, and then just, like you want to sit back. And you'll find the grading, the appropriate grading as, with your body. And again, my hands are doing nothing, it's my hips that are passively driving my hands this way as I'm falling back. Much easier though, I'm working a lot less. Okay.
Still the lateral glide?
lateral glide. That will help
That's
with the
mechanically more of a lateral glide theory than the distraction, because he's going straight out versus down and out.
Lateral glide will help with abduction, inferior glide, which you could kind of do, but that will help with abduction too, but we don't do an inferior glide to the hip per se. All right, just know your mechanics. and what
Before you
you're trying to
unstrap.
achieve. Yeah, I got it.
Do you do any of the mulligan moves
I do.
in that position?
Mhm.
Would you go ahead and show them that? This is one of, this is a great technique. If you're gonna spend your time putting the belt on and getting here, if you assess it and you feel like you could do some treatment in this position, this is one of those home run mulligan movement techniques, movement with mobilization that we showed you a couple of. This is a great one.
So, if you're thinking for this one, I mean, if I had a ball, stability ball, they could, make it easier for themselves and me work less, is put the leg on the stability ball and having them actively come in, or I could just passively take them in, and the ball's just a lot easier for me to control and just work with them. So you're working in the range that you're trying to, achieve, which is flexion, in this case, with a little bit of maybe abduction.
And then the progression, you could even have the patient do it on their own.
Yes.
So you're just putting a little force, and then they're actively flexing.
So you actively do it. So then you're working on
Right.
neuromuscular control, motor learning, again, to fire the hip.
Are you still?
And you're still sitting back?
Yes, Dr. D is
Oh,
great at this, but that's
what I was
exactly what
just
he's
gonna
doing.
ask.
He's sitting back, right? So he's getting the distraction, and then he's weight shifting with the patient. So he's putting the counter force here, right? He's sitting back to get the distraction. Now they're going into flexion and extension, and he's just going with them. Because if he stays still, he's lost the force, right? He wants to keep that lateral distraction, so he's moving with the patient. So if you watch his midsection, basically at his belly button, he's perfectly in line with the knee. He's moving right with the patient as they go. This is a great treatment technique. Not joint assessment. Let's not confuse those, right? So this is an excellent treatment technique, but you're not assessing the joint this way.
And I'm also being mindful of other body parts, right, the back, like what Dr. Heinlein said, and the knee. Because a lot of things you're gonna do is you gotta understand that they might have arthritis at the knee, even though you're trying to achieve at the hip. You gotta make sure you're not squeezing and putting a lot of pressure on the knee either. So just be, keep the hands open and just follow and just be gentle, all right? It all comes together. All right, the other one now is gonna be, we'll go to caudal glide. It's the same as almost like distraction. It's just the way you put your body. So again, what you do is, and here, and then from here I could put something in place if they're not comfortable with this. This is a little, it's fine. And then just from here, push down, inferiorly. Okay, and you find your grade what you want to do, but this is how it is. And you see how I'm stabilized, my back, and again, I could use, I'm using my hands, so I'm stabilizing here. Now, you could change this into a mobilization movement by, again, I could passively take them, or they could actively come in. It's the same thing almost with the strap. So go, pull yourself in, and I just follow. And I weight shift my body. So in this case, I'm not using my arms as much. I'm just bringing my body forward, and my hands are going the other opposite direction. I'm not working hard. I'm doing like a J-swoop mechanism. So Dr. Koo called it, actually, so I started using. So you're kind of like doing this hook as you're coming up, down, and out, trying to get it away from the joint a little bit more. Make sense? So one more time. Go. Scooping and coming up. Scooping and coming up. Okay? And the other way now, it's going to be now we're doing ventral and dorsal glides of the hip. So if I'm going to, you can use your leg too in this case. So if I push down, I usually do if I'm going to be pushing from the front, I'll use a towel. A little modesty. So from here, I'm going to be achieving hip flexion by stabilizing at the knee, the femur, and just locking the arm. And just not even using my arm, I'm just using and pushing down, weight shifting forward. I'm weight shifting forward, and I back off a little bit. Okay? Just like this. So pushing down the hip to achieve this.
Are you on that ASIS when you press
I'm over here,
below?
and below, I got the top proximal femur.
Try to get as close to the crease as you can, okay? So you think about, because you don't wanna be on the pelvis, you really wanna be on the femur. So if you're on the ASAS or the AIS, you're too high up, you gotta come down lower. But think about, you know, the closer you are to the joint, the less force you need to put in, because it's much more directed, okay? So a lot of times, so the towel is a very nice technique, especially for a male-female, even for a female-male. With the belt, you talk about how a lot of times I have the patient, I would ask the patient to position the belt themselves. Like I'll say, you put the belt down as low as you can, so that I'm not pinching anything, I'm not kind of flinging it in there. Oh, and you're like, "Ah."
Phrasing, great.
But once again, get the patient to be participatory, right? So I want you to, you know, move that belt down as low as you can, that's comfortable for you, okay? And then it's already there for you, and all I gotta do is then strap it behind me.
You wanna show us the way you do it with the belt?
For the anterior,
Yeah, I mean for the,
oh, for
yeah,
the,
for
well, you
the
did the
dorsal.
literal one.
I just wanna make
Right.
sure. If you
Yeah,
have
no,
something
no.
else. Okay. So the other way now is if the patient could lie on their stomach, and we'll show you the one standing too, how to get in a walking position, lateral glides of the head with the belt. Okay. So in this case too, sometimes you gotta be mindful of patients, can they lie prone? If they can, but you know maybe they have like back with some, you know, minor arthritis and not really comfortable in this position, you can put one or two pillows underneath the hips to get them more stable, okay, and more comfortable. So that's what I would ask first. Would you like another pillow? You feel okay? So again, you can't see their face. You always want to check in. So the other way is I could do this as well. Now, also with this, I want to be mindful of the sacrum and the low back. So and I'll just do the same thing. Same thing as I did before. It's just reversed. And I'll put a pillow. You're at the gluteal fold. Proximal end at the femur, the gluteal fold, and just again, your nose is also. You want to be like, wait, you want to go forward, so your nose is going to be at or a little past, and then you find the appropriate grade you want to do. See, I'm weight shifting. Very easy. I'm not working hard.
That's the key thing, is just watching. I mean, he makes it look easy because he's weight shifting. So where a lot of times we see as students, you guys are trying, you're trying too hard, you're doing too much with your own arms. This is one where sometimes if they don't have enough, cause so say, if you're looking at doing it this anterior, right, you're trying to get extension, but say they don't have that extension available to them, cause she actually had some nice extension to get up on Steve's knee. At that point then, sometimes you could, cause they're kind of stuck here, you could put a little bit, just to have it like halfway. So then at least with that, you're getting a little, so there's a little space there, okay? I'm not actually pulling her up, but I could even at least try to do something this way. And then this is one where, some people will use the belt for this to help with the leg. Just relax. Yep. So, you know what, I'm actually gonna have you come over to the edge, look over to the edge a little bit. There we go. Just relax. There. Just a little bit more. Right. There we go, see that? So now, her whole weight is just there, and I can actually just go.
Is it around your neck?
It's
Shoulder.
shoulder, okay? So that's another way.
Oh,
You
I
feel
feel
that?
that more than when Dr. D.
Stress. And
Okay?
yeah.
So that's another way. So that's why some of the belts, so sometimes it, once again, makes it so very easy that I'm really there. Now granted, if I was doing that for 10 minutes, I will start to feel that, the weight of the leg on my shoulders. So you just gotta, watch yourself. I would have probably lowered her just a little bit more, cause I don't know if those, you guys saw me on my tippy toes. But this one doesn't really go up and down. So that's the other one. Cause the lateral one, you just showed just kinda going out just straight
Yeah,
without
yes.
going into flexion and stuff, yeah.
Actually, then Dr. Highland said, wanted me to show them, so I did with
Yeah.
passive movement and active movement with
No,
the ball.
that's
We
awesome.
had a stability ball too, to make it easy sometimes. I mean, I don't wanna get too technical or get too much into,
Yeah.
that's where you could go in when you get into the next year, and we'll go into more advanced modes, but you also do get those, work on those gait mechanics, like, terminal extension, you go have them rock back and forth as you have the belt around their hip.
Yeah.
Working extension while they come forward, you're pulling back to really help get that push off, or sideways, so you help bring it out a little bit, so they have better mechanics when they walk. You can do different things like that too with the belt.
Mhm. Yeah, so in adulthood, you guys will come back, we'll teach you more advanced techniques, so the goal of this class is really to get the basic techniques down, okay? All right, any more? That's it, right?
That's it.
We did answer your